everyone, and welcome to OE Headlines, a new podcast show brought to you by the team at OrthoEvidence. My name is Abby Payne, and I'm here safely in studio with Dr. Mohit Bandari, who's our editor-in-chief at OrthoEvidence, and Dr. Brad Petrazor, who's a trauma surgeon and professor of surgery at McMaster University. Brad, welcome. It's so good to see you in person, finally.
I know. I can't believe we're actually able to connect again. And let's just get the record straight. We've got screens. We're distanced. We have both our vaccinations, right? We've got our double vaccination. So I think we're ready to go. And this is going to be great.
It's exciting. Thanks very much for having me.
Problem.
So we're going to kick off today's show first by addressing our OE headliner story, which is our top news story of the day. Following that, we're going to jump into our Fast Five stories, which are the Fast Five stories trending within the orthopedic community today. So Conor McGregor, as most of you probably know by now, has suffered a gruesome lower leg injury at UFC 264 versus Dustin Poirier, who won the match in the first round after McGregor's injury. McGregor's sports agent from Paradigm Sports released a statement on Sunday saying that Conor is in recovery after a 3-hour surgery. The statement read that it was a successful repairing of his tibia and his fibula, and both doctors are confident that with time, he will make a full recovery and anticipate his return to the octagon. So, Brad, MMA enthusiast, trauma surgeon, I don't think we could find a better person.
I want you to walk us through the film and help us understand what went on.
There's some controversy from some camps on that he maybe hurt himself in training. There's some controversy from what Dustin Poirier said at the end of the fight in terms of checking kicks at the beginning of the fight. And then there's a great video, and this video was actually put out by Checkmate MMA on YouTube, and it actually shows a really nice sequence of events that may help us understand when that tibia may have suffered its initial break. Because if you watch some of the fight, he was doing a lot of really hard leg kicks at the front. He got up from a takedown. There wasn't any signs of limping, but then this video here shows something. So there's him at the beginning checking those kicks a little bit, but that one wasn't checked. And these are all the leg kicks he threw at the beginning.
So what do you mean when you say checking a kick?
Yeah, so he's not really checking those kicks. If you can pause it for a second. When you check a kick, you want to bring your knee up and have the kick that's coming in hit the top of your tibia. So you're checking it. You're coming at it. You're not letting the kick come to full power on your thigh.
Okay.
You're bringing your knee up to block the kick before it generated full power, and so it doesn't hit your thigh. Because when you do a large number of kicks on the thigh, you get contusions and all that sort of stuff. Yeah, it does a lot of damage. And if you're there at the fight, you can hear it, hitting. And so anyway, he's not really checking a lot of them. And this is him now. So this is the point. He's doing these up kicks and stuff, and this was after those initial kicks that some people think may have done it, but I'm not so convinced that did. But this one here. Watch that. His tibia has come around, foot's a little bit too far, and he may be hitting his GT there. Boom, comes around, boom there. Now he goes back, and this is the Checkmate MMA team saying, if anybody's kicked a bag the wrong way, it feels like your foot wraps around it. And this is them talking about it. So, but then you watch, then there's that kick. Now just pause it there. Then he does a wobble right there. Yeah. And now the punch, wobble right there.
It's fractured. It's right there.
But he's throwing the punch and go forward. He's coming off the foot. Now he goes back.
Okay, can we stop for a second? So distal tibia fracture based on that mechanism, right? Distal tibia?
I would expect so, yeah. And so the other thing is people are talking about the teep or the front kick that he used, which is kind of a pushing style kick. If you actually look at the video, the right elbow really didn't come into contact because he was still blocking with the left hand. So that video, I think, may kind of explain it, but you can see the buckle, you can see the punch thrown, and then it gives out. So,
let's make the assumption. It's hard to know whether there's an interarticular split or not, but generally that would have been a direct hit. So almost like a transverse small butterfly kind of fracture. Right. Let's assume that you treat that distal tibia. Your treatment of choice, distal tibia evidence would tell you.
Yeah, distal tibia. Let's assume it's an extra-articular fracture, or even maybe a small undisplaced split. I would use an intramedullary nail for that.
And Sprint would tell you limited reaming. basically?
Sprint would tell you limited reaming. Yeah.
Limited. Okay, so you do an interlocked reamed tibial nail, right?
It's probably distal. I'd probably want to use 3 screws. The only thing you don't know is how much comminution is in on that medial side, because he really did go over on it.
Go back to your original paper, Journal of Orthopedic Trauma, many years ago. What were the predictors again, Brad? Of
that's
someone
right.
who's going to have a difficult challenge with
transverse fracture,
right.
high energy injuries, fracture,
open
gaps,
fracture,
open
right.
fractures.
So he's got 2 of them for sure, possibly.
Yeah.
But he was treated, as I understand, by Dr. Little, right, at Cedars-Sinai. Knowing what an expert surgeon he is, I suspect that they spent quite a bit of time making sure that this was an excellent reduction. And
well, it said they spent about 3 hours. So I mean, he's going to spend a bit of time, and they plated the fibula. The only thing we don't know is, how was the ankle affected? Was the syndesmosis affected? With these extra articulars, they can and can't be. Depends. We haven't seen any X-rays, obviously, nor any post-op constructs. So
no, I mean this is basically looking at that clinical appearance, suggesting it looked more extra-articular than intra-articular, and given the mechanism, it was a direct hit, so probably like a transverse style with a butterfly or something, maybe a spiral because you twisted it, right?
Yeah.
What do you think his recovery is going to be like? So everyone's going on around, well, he's out for the 2022 season, but this type of injury, the distal tibial fracture, what are the risks for this type of injury? So we already talked about delayed union, non-union, depending on if there's gap, depending on if it's a transverse fracture, because you get less contact. You really get
energy.
Yeah. What do you think?
Well, I mean, if you look at other people in high professional MMA, Anderson Silva got back after a tibia fracture. I think his was a little bit higher. I suspect he'll probably be able to get back, but is the question as to what level? And again, we don't know what's going on with the joint, so can it develop some arthritic change, etc. Generally, he's going to be probably off it for 6 to 8 weeks and change, depending on, again, what it was, with limited weight bearing and then physiotherapy. I think, being a professional athlete, he may yet get back to the ring, but the question is going to be, what's his level? How is he going to perform? And is there going to be any of that sort of back in the mind stuff? Because if you're not out there full, and you're sort of limiting yourself from a back in the mind point of view, that's also really hard, because it changes your dynamic. It changes the way you compete.
Right. And I remember like the sprint trial, mind you, now we're talking, it would have been 2008 since its publication, the Journal of Bone and Joint Surgery. But I remember clearly some of the secondary papers from that trial that we put out really suggesting that, it does take some time. And in fact, you plateau in terms of recovery. Now, that, the majority of patients in the sprint trial were not, high performance athletes, and very different. What about in a situation like this, that nail stays in, or after healing, is this something that nail will come out?
Yeah, and I personally tend to try and leave the nails in. Sometimes, a lot of the time, I don't know, 20 to 30%. That's just an educated guess that you'd be looking at taking cross screws out if they bug people. But the nail itself will stay in, barring any sort of infection or complication. The fibular plate may or may not stay in. Sometimes it bugs people. The problem is when you take that fibular plate out, then you've got those holes, and he's going to be taking kicks and doing all those torsional things as well. So he's going to need to factor that in too. That plate comes out.
I mean, the only potentially good news is the fibula bears very little of the overall weight. So I mean, getting and let me ask you another question. So in individuals who are usually like in MMA who are doing these leg kicks, is there, like, if you were to X-ray their tibia, would they have like just a thicker cortex because of the repetitive? Like, what's making them stronger?
Well,
and can you get that same degree of I guess strength in the cortex itself?
I
or
think
am I
you
wrong on this?
can. And I haven't seen those X-rays, but people talk about conditioning tibias all the time with the Muay Thai fighters, because they're kicking with the shins a lot,
right?
And down low, and so they're kicking hard things to get them, and you would expect there to be some Wolf's Law hyper type of stuff. The only thing in this instance is, there are some people who have pain at the fracture site, even following well-healed fractures, and how is that going to impede and all that sort of stuff. So
I still remember, I mean, there's been lots of evidence since then, but I still remember papers, even back when I was a resident. Doug Dershowitz did a paper at the Orthopaedic Trauma Association where he says, if you take out a plate for pain, 50% will actually be relieved, 50% don't get relief from plate removal, right? So the reality is there's still a lot of unknowns in this, but given that he is a high-performance athlete, we're anticipating that he's going to probably come back full force, but whether he achieves, ultimate recovery and back to that, what we would consider pre injury level of function on his tibia is yet to be known. Sprint would tell us it takes a long time to get back. Certainly not 6 months.
Yeah.
Right.
Yeah, for sure.
Cool.
So
Wonderful. I think that was great. Thank you so much both for your insights. I think we'll move on now to our Fast Five stories. So these are the stories that are trending within the orthopedic community today. Our first story is cannabis and sports health. So specifically, Sha'Carri Richardson. She's an American track star, expected to dominate the 100-meter dash at the upcoming Olympics in Tokyo. But after testing positive for THC, she's been suspended by the United States Doping Agency and will no longer be able to compete at the Olympics. Her story has caused outrage among her supporters who are criticizing outdated policies and argue that since marijuana is not a performance-enhancing drug, that this policy should be updated. So before we get into a discussion, a few stats for consideration. To date, 18 states plus Washington, D.C. have legalized the recreational use of marijuana. 37 states have legalized the medical use of marijuana. Also, based on a recent study published in Sports Health, it was reported that 1 in 4 athletes have reported using cannabis within the past 12 months. So, Mo, I'm going to direct the question towards you. Is there any current evidence outlining the impact of cannabis and its impact on athletes?
Yeah, thanks, Abby. I mean, it's actually an interesting area, and we've done quite a bit of work in this. Now, this is a paper actually that that we pulled by at least a faculty at McMaster and certainly a few others from Toronto as well, led by Dr. Tim LaRue, and one of our faculty was a co-author, Dr. Moin Khan. There's a number of other individuals, and I happen to be also on this particular review. But here's the point. The evidence overall isn't great. Like it's just not that great. And if you look at the 37 studies or so that were identified, first of all, there aren't a lot of trials, so that's the challenge. There were 11 of them that really focused on cannabis and sport, and that's about 46,000 athletes, and these were elite athletes. And here's the point. To your point, 1 in 4 on cannabis, but there were 4 of those studies that actually looked at performance enhancement, and they found that really there's no evidence for it. Now, you can look at the quality of the data. 2 of them actually found it actually was detrimental to performance, and they had some caveats as to what type of performance. But here's the point. There does not seem to be evidence that cannabis leads to enhancement. One can argue that the area of it being an anxiolytic might be the area, it calms you down in a way that because a lot of sports is psychology, right? There's a lot of that element in it. So there's a possibility, but the functional enhancement has not been determined.
So that's interesting with respect to functional enhancement. If there's actually a potential detriment, does that put any athletes in a difficult situation or for any risk in terms of their performances, et cetera? Do you know what I mean?
Well, if you're arguing anything, you could almost argue that someone on it is probably right. Add a bit of more, but if you're going to argue, you could say almost a disadvantage rather than an advantage in this. Now, it's unknown, so who knows? Right. Who knows? But the point is, though, they're going to continue to be very strong until we get better evidence. It's always the way, right? You need more data to answer these kind of questions. And it's unfortunate because I think her situation is such that she's out of the Olympics fundamentally. And I've understood that her role would have been, like, she was a front runner for the gold medal. And I think, and also for the relay, right? That she would have basically got them to gold, or who knows, this is a perception. But her being out of it is a major, major blow overall. Interesting.
Very interesting. All right. Keeping on track here, our next story, COVID-19. So let's talk immunity here. Many questions remain about both the natural and vaccine-induced immunity to SARS-CoV-2. Cue a new brief that has just been published in the BMJ. So at the end of the day, Mo, people are still talking about COVID. Everyone's talking about immunity, mix matching drugs, matching vaccines.
Mix and matching drugs. Yeah. Take your pick.
What's your take, Mo?
I would say that, the questions that we get, or the questions I think about is, okay, if you get we'll say in this case, the Pfizer vaccine, and you get the Pfizer, initial dose and then the boost dose, can you take AstraZeneca first and then take a Pfizer boost? Can you take the Moderna? And then, so it is, and we don't have a lot of data on that. And that there's early stuff that suggests maybe that there could be some benefit. Some would even argue there may be more benefit, but again, there's no data on it. The question that is coming up more and more is, well, when do we need a third booster because, you know, there's going to be many people now approaching 12 months or getting close to 12 months. How long does this immunity truly last? And the booster really should be about, okay, you know, are we going to manage all these variants? You know, there's a pile of variants, including the new Lambda. You know,
Right.
you've heard about that.
Yep.
And the Delta variant is the one right now that's kind of creating a ton of problems in terms of, you know, challenges. So, you know, a lot of unknowns, but I do think right now that Pfizer has applied, right, to the FDA for that third 12-month booster. And there's going to be lots and more, you know, sort of design vaccines to say they're going to go targeting these variants. When they happen, how quickly it happens, I'm not sure, but they're going to need trials. And this gets back to this thing that I think COVID, for example, if you look at the fourth waves that are pending, all the data, at least at this point, suggests, if you look at Cuba, for example, like they're being ravaged right now, right, with COVID. It's really quite, horrible what's happening.
Yeah.
Many countries are facing this. And what's happening is the fourth wave is typically happening with unvaccinated individuals, right? And so one of the arguments is, you know, we can keep looking for treatments, but we've got to get people vaccinated in a way. When I say we, that the general policies are getting people vaccinated to 70 to 80%, and many countries are nowhere near that 70 to 80% mark where we talk about herd immunity. So it's a moving target right now, and we just got to keep, you know, being careful not to get caught up in the noise and just focus on the evidence.
Wonderful.
That's all I got. I'm done. I got nothing else. Brad, you must have something to say about this.
Well, no, I mean, I do, but there's biologic rationale for lots of things.
Yeah, I bet.
Wonderful. So moving on. So best interventions for surgical infections. So this is an OE insight that we recently just published. So this insight in particular had huge hits this past week within our OE community. Despite many advances in the field of surgery, surgical site infection remains an ongoing public health concern. So our guest contributor, Jay Parvizi, who's renowned for his leadership and research in the area of infection management, he gave his input, a 10-step approach on how to prevent surgical infection. So we're going to pull that graphic up now. So we have a 10-step approach here. Mo, what are your thoughts?
Well, first of all, let me just say that, you know, getting Dr. Parvizi's collaboration on anything we do always is, you know, it's a great insight to getting more information out, and certainly, and his ability to distill information. So if you look at his approach, and certainly it's one of, you know, and he's the first to tell you that this is just his approach, but he's using evidence, I believe, very carefully. When you look at that though, Brad, there's lots of steps in infection control. When you think about for yourself personally, now obviously you're not doing total joint replacement in the same way. What's your critical step in infection management? And I think the follow-up question I would have is, where do we focus on evidence thereafter?
Yeah, I mean, so there's issues around the important ones, I think, are pre-op optimization, expeditious surgery, the antiseptics, obviously, and irrigations and antimicrobials, respect for soft tissues and all that. I think they're all very important. Obviously, some of the medications, the antiseptics, the things that we do intraoperatively to prepare the limb, to prepare the surgical site for infections are very important. Having everybody in the room being cognizant of it. The preoperative optimization is important. I mean, diabetic control, albumin levels, things like that do have evidence behind them to be shown that those need to be optimized. And the appropriate antimicrobial given at the appropriate time before the surgical site, all that sort of stuff. It's multifactorial. And that's the issue about just making sure that the team is always aware of why you're doing what you're doing.
When you look at Lancet Global Health, right, in their directives and the group that met, and they said, you know, we need to be thinking about open fractures, right? Open fractures is one of their bellwether procedures. And they said, you know, this is around the world an area where we have to have mandates for optimization. And one is early treatment of an open fracture, right? Rapid treatment of an open fracture and initial management of an open fracture within that 2-hour period. Right. What are we doing in that early 2-hour period for infection prevention in an open fracture? That should be the standard, whether you're in Central Africa or in the United States or Canada.
Well, wound toilet as soon as possible. So by that, I mean some form of irrigation, some form of and reduction to make the limb look like the limb. But antibiotics, antibiotics given as soon as possible. There's a NNT of roughly 13 to 15.
NNT, use a fancy term.
There's a number needed to treat of around 15, depending on the research that you look at, to suggest that for every 15 patients you treat with an antibiotic, you're going to prevent one infection. That's a lot. That's big. So the biggest things are, as soon as you can, wound irrigation. And there's evidence to suggest that potable water may just be as good as saline. Now, those trials are very small, but there's evidence to suggest that the sooner you get the wound clean and the sooner you get antibiotics in, you can try and at least, you will prevent some infections.
Yeah, I got it. Well, my whole thing on this general point overall is the following, which is, simple things matter, and there is no one magic bullet, right? I think we hear when you have 10 steps, each step matters, and each step incrementally gets to the point. So yeah, great stuff. And again, a really great insight. I recommend those who are listening here today or watching, get a hold of that insight and take a read of it.
Absolutely. Okay, so next up, we have redefining the future of surgical care. Another OE insight that our team at OrthoEvidence had published very recently. A great variety of advancements are being made and adapted in surgery that have the capacity to improve surgical practice. Our team did a breakdown of 6 exceptionally promising and increasing studied innovations. These include robotics, augmented and virtual reality, biologics, 3D printing, and post-operative care, and big data. So we surveyed our community to see what they believed was the most innovative advancement. So before we put up that graphic, Brad, what would you say would be your most innovative practice out of the ones I just listed?
So let me ask you this. Before we put the graphic up, if I said to you, what's the biggest innovation coming to us or coming, in the horizon? For you, what is it?
I still think biologics. We haven't figured it out yet.
Yeah, for me, I think it's big data. I think data is the oil. Obviously at OrthoEvidence, we've always thought about it that way. But I'm curious to hear what everyone else said.
All right, let's see it.
Robotics.
Okay, so top 3, robotic surgery, augmented and virtual reality is number 2, and 3D printing is number 3.
Interesting, right? I mean, we're seeing a big push from many institutions and companies to put out robotics. But what do robots need? Data, a healthy diet of good evidence, right? That's what they need. So anyways, I think we're all the same.
But you see, robots can't help with the biology.
Well said. Well said. There you go.
When you teach someone to, and I'll stop.
When
you teach someone to tie your shoes, you don't give them a visual reality thing. Virtual reality.
Yes.
Show them how to tie their shoes.
Right. But that being said, we are not saying that robots, virtual reality, and 3D printing are not innovations. We're just simply saying, hey, there are some principles. Biologics still is out there, and certainly data is out there. Great. Awesome.
So moving on to our 5th and final story. Now, this study isn't necessarily new to the orthopedic community, but it is an extremely important topic to be discussed due to the nature of the study. So to cement or not to cement? Hip fracture arthroplasty. So according to a study published in the Journal of Arthroplasty, cemented fixation had a statistically significant reduction in mortality rates at 30, 90, and 365 days. Mo, why are these mortality rates so much higher in cementless fixation?
Yeah, and this is actually also a highlight paper too, Abby. It was a highlight paper at the recent meeting of the Canadian Orthopaedic Association. And this is work led by Glenn Richardson, and I believe the senior author here would have been Dr. Michael Dunbar. And, it's interesting that there's been a debate around cemented versus uncemented arthroplasty or some sort of arthroplasty, but it's hemi or total in patients with hip fractures. And I did ask him, specifically, what is the hypothesis around uncemented being problematic? What would you think, Brad, from the point of view of uncemented arthroplasty? What would be, in your mind, the pathophysiology of why that group is faring much worse, mortality-wise as well as revision-wise?
Well, you said 2 different things there. You said mortality and then you said revision.
But really, revision itself has, in that patient population, could in fact be related to mortality.
Yeah, I mean, truthfully, you and I have chatted about this, and this controversy goes back years when I was a fellow about cemented. And people always thought the cemented, you might get this fat emboli and it might be reversed. So I honestly, I don't quite know unless, as we've talked about before, there's an increased incidence of intraoperative fractures with the calcar, or just the complexity of surgery, or something about revisions like you mentioned.
Yeah, like the post-operative, post-operative periprosthetic fracture, I would imagine they're pretty devastating injuries, especially in that patient population, remember.
Yeah.
Right?
Yeah. It means another surgery.
Yeah. And it seemed, to your point, it seemed to be, when I asked the same question to Dr. Dunbar, he seemed to sort of echo that it's likely related to that particular type of revision. But again, this work that they're doing suggests mortality. Before, it has been more revision, and that's been the driver of mortality. The other thing that's interesting is there's wide variation in practice, and he talked about across Canada, and that was also somewhat alarming for him. So this is really a way to advance some of his call to action, which was, let's get the message out and let's get people talking and debating about this. And the evidence itself should tell the story.
Mm-hmm. Yeah, I think it's interesting, really, because if it is about that revision stuff, then you're right. He needs to talk about it.
Yeah.
So any final takeaway messages there?
In my mind, it seems fairly clear that there's mounting data across multiple data sets, and more recently, you're seeing even in this particular case, large data sets suggesting cemented arthroplasty may be a safer option, both with respect to survival and respect for revision.
Mm-hmm.
I think we've got to get those recommendations that are discussing this out to a broader population, and certainly continue researching this in a careful way.
Wonderful.
Yep.
Well, I think that's it. I think we're out of time officially. So thank you both so much for joining us today. And thank you to our OE community for joining us for our first OE Headlines podcast. We're looking forward to bringing you more news in the future. If you do have any topics or questions that you'd like covered or seen in upcoming episodes, we ask that you please email them to headlines@myorthoevidence.com. Well, Brad, thank you again.
Thank you. It was great.